Hi, good morning, everyone. I hope you can hear me. I was having a bit of audio issues before, but my name is Beth Colella. I'm from Bristol Myers Squibb and a member of the Pediatric Working Group with IQ. And I have the pleasure of introducing our speakers today. But before I do that, I would like to mention that after we conclude today, you will receive an email with a feedback survey from Mahalea, and we do appreciate your feedback. So thank you in advance for that. Also, if anyone has any interest in presenting at this forum, please feel free to reach out to myself or to David Tan. Without further ado, I will go ahead and introduce our speakers. Our first speaker today is Dr. Anita Su, and she is a clinical professor, the vice chair for teaching and learning, and director of faculty mentoring at the Ernest Mario School of Pharmacy at Rutgers State University. She is a neonatal pediatric pharmacotherapy specialist and practices at the Hovnanian Children's Hospital at Jersey Shore University Medical Center. At the Hovnanian Children's Hospital, Dr. Su is a board-certified pediatric pharmacy specialist and has created her own clinical practice serving as a liaison between the Department of Pharmacy and Pediatrics. Dr. Su earned her bachelor's and doctorate in pharmacy from the University of the Sciences in Philadelphia and completed 2 years of pharmacy residency training, general pediatrics, and neonatal pediatric critical care. She was also the first pharmacist inducted as a member to the Stuart D. Cook Endy Masters Educators Guild at Rutgers University. Dr. Su has also served 2 terms as chair of the Specialty Council for Pediatric Pharmacy for the Board of Pharmacy Specialties, the board certification for pediatric pharmacists. In 2021, Dr. Su was appointed and began her service to the board of directors for BPS. Also, we have Dr. Pooja Shah, who is currently a clinical associate professor at the Ernest Mario School of Pharmacy at Rutgers University, where she received her Doctor of Pharmacy degree. She completed a pharmacy residency at Hackensack University Medical Center and a pediatric pharmacy residency at the University of Chicago Medicine. She maintains a practice site in pediatrics, specializing in neonatal intensive care at Hackensack University Medical Center. She provides additional clinical consult service to the general pediatrics service and the pediatric epilepsy and neurology unit. Her interest areas in research and publications include optimizing medication use in neonates, pediatric infectious diseases, and pediatric medication safety. Pooja is actively involved in professional organizations, including the American Society of Health Systems Pharmacists and the Pediatric Pharmacy Association. So thank you very much for speaking, and I will turn it over to you. Thank you.
Thank you, everyone, and thank you for joining today. And thank you for the introduction, Beth. As everybody heard from my background, my name is Anita Su, and my co-presenter is Pooja Shah, and we're going to be presenting on medication use in neonates, small patients, but they do really have some big problems. And let me, oh, there we go. Sorry about that. Okay, so we have 3 primary objectives that we do want to focus in today's presentation. Our first main objective is really to identify the characteristics of what's considered an ideal intravenous medication, specifically for the neonatal population. And when I mention neonatal population, I am discussing a group of population that are specifically from birth to the first 28 days of life, just to give some people some perspective. So our presentation really focused on this small population and young group of neonates versus us diving deeper into the pediatric population. So we'll focus on more on the neonatal population. We're also going to discuss about medication excipients and the importance of osmolality of oral products that are primary use, especially the most common medications that we see in this population. And we'll describe some common dosage formulation manipulation that unfortunately we have to do in clinical practice and families have to do at home in order to get the right medication and the amounts specifically dosed for that neonate. So Pooja and I currently have no financial relationship or anything to disclose, but we do want to mention majority of the medications in our presentation will be considered off-label use of medications, as many of them has not been FDA or approved by certain legislations for the use in neonates. I first want to start off with some background information, and the next few slides is really just to go over all the different legislations that have gone through over the years and how this has helped in promoting pediatric clinical trials. So as we can see in this timeline over here, this timeline basically shows what has evolved over the time period, beginning of 1938, where we had the Food, Drug, and Cosmetic Act. But the four main legislations that I do want to discuss that's really helped us over the years and continue to help us in developing medication production in pediatric population is the 1994 FDA final rule on pediatric labeling. We'll also talk about the BPCA, which is also known as the Best Pharmaceuticals for Children Act, and as well as the FDA Modernization Act, the FDA-MA. And then we'll also talk about the PREA Act, which is the Pediatric Research Equity Act that came out in 2003. The two main legislations is going to be the BPCA and also the PREA. So what are they? So to kind of summarize what they are, this kind of gives you a timeline of what each individual description has when the legislations came out. In 1994, when the FDA final rule came out on pediatric labeling, it allowed pediatric labeling permitted from adult extrapolation, looking into more of the pharmacokinetics and pharmacodynamic data safety that's available. Then the FDA Modernization Act allowed extensions for manufacturers if it was conducted in pediatric clinical trials and the indication was there. It provided another additional 6-month patent extension. However, the biggest impact really was the BPCA and also the PREA. As you can see from the BPCA, it identified drugs requiring pediatric trials. But not only did it do that, it actually allowed the FDA, which is the Food, Drug, and Administration, to issue studies in pediatrics. And it also increased funding from our National Institute of Health to allow more funding to be done so that they will promote scholarly activities and research activities for more pediatric clinical trials, whether it be neonates or pediatrics for these legislations. The additional thing that the BPCA also emphasized was allowing for another 6-month patent exclusivity, and which was an incentive for the manufacturers to actually do studies in the pediatric population. Then we had the PREA, which is the Pediatric Research Equity Act. And this was all new drug applications requires a pediatric assessment. So it basically required pharmaceutical companies and manufacturers to study their products in the pediatric population, and allows the FDA to have authority in which it requires pediatric studies in certain drugs and biological products. So why the focus for the PPCA and also the PREA is because ever since these were available, it allowed really the study of safety and efficacy of how these medications do work in about 400 drugs found in the neonatal, infant, children, and adolescent population within the first 5 years that they were implemented. So even though they were issued 1 year apart, within the first 5 years, we had more than 400 drugs that were studied and looked into the population that was considered very vulnerable. So they did make a huge impact. And due to the success of this legislation, as you can see, this progressed and went on. So then we had additional legislations. In the last few legislations that you can see, the FDAAA, the FDA Amendments Act, the FDA Reauthorization Act, originally when the PREA and the BPCA, they were due for a 5-year expiration in these acts. However, additional production of these legislation acts allowed it to become permanent in its legislation, and hence why it evolved. And you can see in the latter years of these pediatric legislation, we started focusing also on oncology medications in peds. So we do hope to see, as future does evolve, more and more studies coming out in the research area for neonates and pediatrics. Unfortunately, majority of the time, especially in the neonatal population, we do use off-label uses of medications. So what do I mean by off-label use? It's basically a use of drug that is not included in the product information or package insert for that drug. And the purpose is to really benefit the individual patient, but the absence of labeling for a specific age group or disorder does not mean that it's improper for this age or this disease state that they're treating for. And it also does not mean that it is per se illegal or also contraindicated or even investigational use. But there has to be some type of justification in order to allow its use in the neonatal population or pediatrics. So an example would be back in 2014, the American Academy of Pediatrics, also known as the AAP, provided off-label use recommendations to provide some guidance to prescribers and healthcare providers as to what should we do when it comes to off-label and what's considered an off-label and still considered safe in this population. So in this case, the prescriber is considered responsible for deciding which drug and dosing. And hopefully they have a collaborative interprofessional process where there's also a pharmacist included and other healthcare professionals as considered experts, expertise in this area, also making this particular judgment. Because the information on the drug labeling will also help us. We do need to provide clinical experience and expert medical judgment, and also any published literature. And now when I say any, I mean any. Case reports, reports that maybe just an older population, like for example, children, adolescents versus the neonatal population. And also, we also want to advocate for necessary incentives and requirements to promote the study of drugs in children. So hopefully, even though many of these medications were done and used in off-label and not per se indicated for that age population, we're hoping to increase the availability of literature and research to the neonatal population. And now I'll turn over the presentation to Dr. Pooja Shah.
Okay, thank you for that. Like Beth and Anita introduced, my name is Pooja Shah, and I'll be speaking for the next portion of this talk. So despite the great advances that were just reviewed made in pediatric labeling and studies due to BCPA and PREA, FDA approvals and clinical studies, the neonatal population still lags behind. So this is a chart. This is as of 2017, 708 drugs were now labeled for pediatric patients. This sounds like a great advancement, but when we look at that and compare that to our neonatal patients, there were only 46 drugs that were formally studied in neonates, which led to 35 neonatal labeling changes, and then 20 of medications were indicated for neonates. In addition, there were 2 drugs that had enough of those case studies and literature publications that Dr. Su reviewed that led to additional indications. A common question that I always get asked is, there's very few medications that are labeled for neonatal use. And I get this question even from fellow healthcare professionals that are not in the pediatric or neonatal space. And this question is, how often do you really use medications in pediatrics? Does it matter that there's only 20 medications that that have the indication for this patient population? Trouble advancing. So when we look in clinical practice, off-label medication use in the NICU has been reported anywhere from 34% to 96.5%. This incidence varies largely based on the patient population that you're looking at, whether it's a low birth weight critically ill neonate or a term neonate that's just admitted to the neonatal intensive care unit for feeding difficulty. Furthermore, 44 to 100% of all neonates that have been admitted to a NICU have been noted to prescribe an off-label drug based on the literature. In this study published by Costa and colleagues, they reviewed all medications that were administered to neonates between 2015 and 2016. So keep in mind, this is well after PREA and BCPA have come underway. Manipulation of medication was into a liquid dosage form was actually described as the most common manipulation that was necessary in order to administer these medications to neonates. A great reason why this talk is so important today. Knowing that neonates are the most vulnerable patient population prone to medication safety issues, adverse effects, and medication errors, it's very vital that we understand how these medications can be used safely and effectively in this population. I'm just going to briefly go over, even within this NICU or neonatal population that we talk about, this population is actually very heterogeneous. Within pediatrics, neonates are considered a separate group. However, understanding that the pharmacokinetics and pharmacodynamic differences between the various age groups within this identified neonatal age group of the first 30 days or 28 days of life will help optimize the safety and efficacy of medication use. In addition, we have significant pharmacokinetic and pharmacodynamic differences due to variations in organ development depending on when the patient is born and their gestational age. This can significantly impact how medications are used in children. So the neonatal period, as Dr. Sue had alluded to, is defined as the first 28 to 30 days of life. However, in clinical practice, it's extremely vital to understand that gestational age of the patient is going to greatly affect their organs that have developed, the kinetics and the dynamic differences between these different age groups. So patients are classified based on gestational age of the neonate, and gestational age is the time from conception to the time of birth. Term gestation is a term you may hear frequently. This is essentially if the patient was born between 37 and 40 weeks of life. Late preterm infants are anywhere born between 32 to 37 weeks of gestation, and then very preterm and extremely preterm neonates defined as 28 to 32 weeks birth gestation, and then less than 28 weeks of gestation respectively. These last two groups are the most vulnerable and the most likely to be prescribed an off-label medication or a medication without any significant data behind it. To make things even more complicated, the weight of the patient will affect the dose of the medication that's administered. I'm going to be explaining how it's a balancing game of when we're looking at different IV medications and why it is very complicated to make IV medications ideal for this population. These weights are important to keep in mind as we move through the discussion because it's going to greatly impact the administration of medications and the dosage forms that we would be prescribing. Low birth weight is defined as patients that are born less than 2,500 grams. Very low birth weight is designated for patients that are born less than 1,500 grams. Extremely low birth weight are patients that are less than 1,000 grams. And I'll say clinically, these patients have a lot of medication administration and dosage form issues. And then micropreemies are even more susceptible to these issues. The micropreemies are defined as patients who are born less than 20 weeks gestation or less than 750 grams. When we talk about fluid requirements, so nutrition is of utmost importance in these neonatal patients, and total fluids are important to understand since all neonatal nutrition and medications will contribute to this total fluid allowance per day. Normal fluid requirements in any neonate are between 100 and 140 mLs per kilo per day. And in fluid restricted patients, we would say a requirement of anywhere between 60 to 80 mLs per kilo per day. In a 600 gram infant who's going to be receiving normal fluids, that would be anywhere from 60 to 84 mLs. If they were fluid restricted, we would bring that down to about 36 to 84 mLs. In a 3 kilo term infant, their daily fluid requirements are anywhere from 300 mLs to 420 mLs. If they were fluid restricted, that goes down to 180 mLs to 240 mLs. So bringing this into practice, so premature and low birth weight neonates may be on 8 to 10 IV medications, and that contributes heavily to this daily fluid goal. Medication volume needs to be minimized so that we can maximize nutritional fluid. What is nutritional fluid? So for patients that are able to take enteral feeds or things through their mouth or through a nasogastric tube, that's either breast milk or formula. If they're unable to use their enteral route, and if they're going to be on IV fluids, that essentially means total parenteral nutrition. Critically ill or premature or low birth weight neonates are going to have a very low amount of fluid that's going to be allowed to them. Even in term neonates, we will often run into this problem where the medications contribute heavily to that total fluid allotment, and therefore then we're not able to maximize how much nutrition they can receive. Here's an example. This is a 3 kilo fluid restricted patient. This is actually a patient from my practice that I recently have encountered. This patient was critically ill and was on multiple sedation and analgesic medications, as well as inotropic medication. They were fluid restricted because they had significant pulmonary edema, and they were in complete renal failure. So we were unable to remove any of the fluid through urine. So just looking through, these are the most concentrated medications that we have as part of our standards at our institution. Utilizing those concentrated medications, they were on inotropes such as dopamine and norepinephrine. They were on sedatives and analgesics, including fentanyl, midazolam. They had seizures, so they needed phenobarbital. And then the patient was also hyperglycemic, requiring an insulin continuous infusion. And then in order to try and make some urine, we were giving them furosemide or Lasix. The total fluids that the medications contributed to were 114 mLs per day. This doesn't include flushes, and we'll go through what flushes are and why they're necessary, but this doesn't include any flushes. It doesn't include any nutrition. So a huge component of their total fluid allotment, which if we recall, it's about 180 mLs, was coming from just their medication. So this is a significant problem that we run into quite frequently in our patients. I mentioned this is a balancing game. So we don't want medications to dilute because they'll contribute largely to non-nutritional fluids. On the other hand, sometimes for our micropreemies, especially, and for our very low birth weight infants, we don't want medications that are too concentrated because they create a line and pump delivery problem. So what does that mean? Pumps require a minimum volume that can be accurately administered. These rates will vary depending on the type of syringe pump. A syringe pump is commonly used in the neonatal intensive care unit because it allows a more accurate delivery mechanism for small rates and volumes like we see in the neonatal and pediatric population. The minimum rate for continuous infusion, and so that a continuous infusion is a medication that's running throughout 24 hours, will depend on a syringe size that's used. Typically, the syringe size that's chosen is dependent on the 24-hour fluid volume. So just a quick example, if a medication were to run at 0.3 mLs per hour, an appropriate syringe size would be about 10 mLs to allow the total daily 24-hour rate, plus a little more volume so that the line could be primed and then flushed after. Intermittent medications are even more complicated because they have typically a minimum infusion volume of 0.1 ml that can be accurately administered. So here's just an example, 1 ml syringes. If it's a continuous rate, you could go down to 0.01 ml. Similar for a 3 ml syringe. For 5 ml and larger, you can only go down to 0.1 ml for a minimum hourly rate. In clinical practice, the 1 and the 3 mLs are rarely used because they don't provide enough fluid volume. We don't actually have 1 ml syringes that are compatible with our syringe pump, so our minimum is usually a 3 ml. And for continuous rates, we will usually choose a 5 ml syringe or larger because we can't have the nurses turning over syringes. Otherwise, you're going to have lag time for when the patient's going to receive the medication. A great example of this intermittent medication issue that comes to mind that I deal with probably on a weekly basis is indomethacin. So if you recall, the minimum volume that can be administered through an intermittent administration is 0.1 ml. So standard concentrations of indomethacin that have been that are stable range anywhere from 0.5 to 1 milligram per ml. The standard dose of indomethacin is anywhere from 0.2 milligrams per kilo to 0.25 milligrams per kilo, depending on the day of life. So here we have an example of a 1 kilo patient, and they would be getting 0.2 milligrams per kilo, so their dose is going to be 0.2 milligrams. This equates to an administration volume of 0.4 mLs. We are required to give indomethacin over an hour to minimize the vasoconstrictive effects or minimize the negative vasoconstrictive effects. So if we were to give a volume of 0.4 mLs per hour, it would take us about 3.75 hours for the medication just to reach the patient. This takes this long because you see this tubing picture. So usually our tubing volumes are anywhere from 1.5 to 3 mLs. Sometimes we can get smaller volume tubing that can be about 1 ml, but again, that's still going to create an issue for 0.4 ml medication. So what this requires the nurse to do, there's two options. They either manually prime the line and basically bring the medication to the tip of the tubing, or they'll manipulate the syringe pump, put in an artificial rate so that it'll quickly travel through the tubing. Once it gets to the end, then they'll program it to be administered over an hour. Both of these options are not ideal, they're not safe, but it's what we need to do in order to get this medication to the patient. It's important that healthcare practitioners are understanding of these complex work processes, because if you don't understand this, the patient may never receive the medication, or you may be waiting quite a long time for a medication to actually reach the patient. And in a case of something like an antibiotic, where time is of essence, you may be delaying appropriate patient care. The next thing I want to discuss, or another issue with intravenous medications that occurs for neonates, is with IV compatibility. As I alluded to before, neonates are on anywhere between 8 and 10 medications. Very low birth weight infants or extremely premature infants are often unable to tolerate enteral feeds for the first few days to weeks of life. So they're often on these medications intravenously. Co-administration of incompatible drugs can lead to either precipitation or degradation of the drug, and that can lead to medication ineffectiveness. Neonates, many of these medications are continuous medications, so analgesics, sedatives, and inotropes. These are on continuously, so it doesn't allow for us to give multiple incompatible intermittent medications. These patients also have total parenteral nutrition, which is often either not studied or incompatible with medications. Total parenteral nutrition also is given over 24 hours. So it makes it very complicated when you have multiple continuous infusions that are non-compatible. Concentrations of medications also need to be adjusted based on volume needs and administration concerns that we just discussed. So we'll go through why the concentrations become issues, because sometimes the information that we have on compatibility is limited to a specific concentration. However, we just spent significant time talking about how we may need to have something very concentrated or very dilute. In addition, neonates are particularly vulnerable because they have very limited options or access for new lines. It's very difficult to sometimes get a line in these patients. It can take some time. They don't have great veins to use. Some medications may require central lines for administration, so we're not able to just give it multiple peripheral lines and administer multiple incompatible medications. And then neonates do have the option of having umbilical lines. However, these are only good for really 7 to stretching it to 10 days, because it does lead to a risk of infection if they're prolonged. So just to give you some background information on intravenous medication setup. So here we have a single lumen connector. This is one infusion that goes through a line and goes to the patient. Here, we're not really worried about compatible issues. If the patient was only on intermittent medications, you could just give one drug, provide a flush to clear the line after the drug, and then give the next medication. These patients are often not on just intermittent medications. They have continuous medication needs, or they're on total parenteral nutrition. Another option for medication setup is a Y-site connector. So this is where you have 2 infusions that are running simultaneously. Initially, they are separated, but they do mix at a central point before they reach the patient. So here you are not able to give medications that are incompatible through a Y-site. An ideal solution is a multi-lumen connector that you see here. This is where you have multiple infusions running through a central line, so there's only one connection to the patient. However, there's no mixing of the medications. Unfortunately, these multi-lumen connectors are not an option for our neonatal patients because these lines are actually quite wide, and our veins for our neonates are quite small, especially for our micropreemies. So these are just not an option. So what we've done, or what's been created for our neonatal patients, are multi-lumen connectors. So there's 1 lumen, bi, tris, or quads. They're either bi, tri, or quadricated to allow medications to be administered simultaneously through 1 lumen, but you can give multiple medications through these different access points. They do meet in 1 line before they reach the patient, so we can't give incompatible medications through this port. It just makes it easier for us to give multiple medications using 1 access point. The other benefit to these is that they have inline filters built in so that you can use these for TPN and lipids, which do require 1.2 micron or 0.2 micron filters for administration. So just to illustrate some of the common compatibility issues that we see in practice. So again, I alluded to many of these patients are on total parenteral nutrition, and finding information on compatibility with total parenteral nutrition is complex. In addition, a lot of medications are not compatible with TPN. Options that we have in practice to overcome these incompatibility issues is 1, you can add an additional peripheral line for a medication. This is not ideal because, again, we have limited access sites. You're introducing a new line, which can potentially increase the risk of infection in an already immunocompromised population. You also can temporarily discontinue total parenteral nutrition. However, this is also not ideal. It's labor intensive because you have to titrate the TPN up and down to prevent hypoglycemia. This also leads to poor nutrition because the patient is not getting nutrition in those specific hours that the TPN has been held. A very common issue that we see in practice with TPN incompatibility is the use of amphotericin, which is an antifungal agent. It is the first line antifungal agent in our neonatal practice. So you see here, when you look at the TPN compatibility with amphotericin, it is not compatible. In practice, what we often are forced to do if we're not able to get a peripheral line is we are forced to hold the TPN. This is also not ideal because you see here, the infusion of amphotericin has to be done over 2 to 6 hours. So oftentimes our patients are without TPN for about 4 hours a day. This is because it takes an hour for us to flush the line with dextrose when we stop the TPN. Then we administer amphotericin over 2 hours, and then we flush it again with dextrose over an hour. And this is because amphotericin cannot be mixed with saline at all because it causes a precipitation. Other compatibility issues that occur is that there's a lack of compatibility information with commonly used medications. So it just it says not tested. There's incomplete information with desired concentrations. So a good example of that is this is ampicillin. You see here, it says it's incompatible through the Y site. However, we have no idea what concentration this incompatibility actually is. Another issue is that there's incompatible drugs with limited alternative options. So amphotericin is a classic one. There's really not another first-line antifungal agent that we'd want to use. So we are forced to come up with creative options. And then sometimes there's a lack of admixture information. So can you mix a medication in a higher dextrose concentration? Oftentimes our patients are hypoglycemic and need more dextrose or lower sodium concentrations. You see here with information with limited concentration. So this is ampicillin again. You see that it is compatible with 20 milligrams per ml. It's incompatible with 200 milligrams per ml. Our clinical practice actually uses 30 milligrams per ml, yet we have no information on whether it's compatible or not. So we make our own internal decision and extrapolate the information based on what's available. But again, it would be nice to have that information available to us. So just to summarize, ideal characteristics of a NICU IV medication should have customizable concentrations, should have adequate compatibility information. Studies need to be done to ensure safety and efficacy in the neonate, and then it should be free for harmful excipients. Harmful excipients span not only intravenous medications, but also oral medications. And I'll go through some of the excipients that are of most concern. So excipients that are reported with concern for safety in the neonatal population include ethanol, propylene glycol, and benzyl alcohol. These are ones that are that have reported negative outcomes in the literature. Parabens, sodium sulfites, and artificial sweeteners are less preferred. However, they don't have documented harm in reported in literature. So these are ones that it would be nice to be removed from, but it's not as detrimental as the ones on top. With regards to ethanol, there is an FDA max concentration recommendation for children under the age of 6. However, our neonates are a very unique population in the sense that we want to try and avoid ethanol at all if possible. Propylene glycol, the FDA has communicated, FDA drug communication has highlighted significant adverse effects in preterm infants that have been exposed to drugs with propylene glycol. The one that was most recently reported was lorazepam with high concentrations. Benzyl alkylonium chloride can cause bronchospasms in pediatric patients. It's often used as a preservative or stabilizer. Interestingly, this is a stabilizer that's often used in albuterol, and albuterol is used for patients that have asthma and that are experiencing bronchospasms. So it's another one that we have to kind of work around. And then benzyl alcohol is probably the most well-known excipient that has caused harm in neonates. It normally is rapidly oxidized to benzoic acid. It interferes with the immature liver, and then it causes a drug accumulation and causes metabolic acidosis. Affected infants have high daily intakes of benzyl alcohol that ranges from 99 to 405 milligrams per kilogram per day. It leads to metabolic acidosis, seizures, and gasping syndrome. So little is known about the toxic effects or levels of benzyl alcohol specifically in sick premature infants. So ideally, we would avoid it if possible. Otherwise, we just try to minimize it below that 99 milligrams per kilogram per day. When we look at specific drugs in practice that have this issue, the first that comes to mind is dexamethasone. We often use this for extubation or for bronchopulmonary dysplasia prevention. There's a few formulations of oral dexamethasone that are available. There's dexamethasone oral elixir, that's 0.5 milligrams per 5 mLs. This formulation contains propylene glycol and alcohol. Then there's dexamethasone intensol, which is 1 milligram per ml. However, it contains a high amount of ethanol in that formulation. Oral solution of 0.5 to 5 milliliters is often too dilute for some patients, and so we need a more concentrated form. So in practice, what we do for our neonates is what we actually do an off-label use, and we just use the intravenous formulation, which is preservative-free, and we give it orally to overcome the issue with concentrations, and it doesn't contain any preservatives. But it would be nice to have a preservative-free oral solution that's appropriately concentrated that we can use for our patients. Another common request that I get probably every single week is the use of buprenorphine. So recently, buprenorphine has gained great momentum because clinical studies have demonstrated that there's great efficacy when it's used for the management of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome compared to alternative therapies such as morphine. The studies used an oral formulation that they made. They used the buprenorphine. There is a buprenorphine for injection that's available. However, the oral formulation that was used in studies used 100% ethanol, which contains 30% of final ethanol concentration and simple syrup. A big critique of the study is because we were giving these patients such high concentrations of ethanol, did we just see less withdrawal because we were basically giving them ethanol? The final concentration that was used was 0.6 milligrams per ml. So it would be nice to have a commercially available preservative-free formulation in the correct concentration so we can actually use this in practice. Currently, we actually don't use buprenorphine because I'm not comfortable with the high ethanol concentration that the study used in order to provide this medication to their patients until we have more long-term information. Finally, I alluded to phenobarbital. It is one of our drugs of choice for the management of seizures. When you look at the oral liquid, the only one that's now available is the elixir. And this elixir contains 15% alcohol in the oral solution. There used to be one with less alcohol and no alcohol. And since for the past couple of years, it's been removed from the market. So it would be also nice if there were alcohol-free or preservative-free versions of this, since our patients can be on this for quite some time. And then finally, when we see the IV formulations for excipient use, there's benzyl alcohol. So bacteriostatic water for injection contains 9 milligrams per ml of benzyl alcohol as a preservative. And specifically, when you look at the container, you can actually see it does caution healthcare providers not to use this in neonates, but this enough of this benzyl alcohol could accumulate, especially when these patients are receiving 1 ml flushes between all of their intermittent medications. So again, that can be at minimum 8 to 10 mLs that they're getting just from flushes, in addition to other uses for water where they may be diluting medications as well. So this can potentially lead to a significant overdose if this were to be inadvertently administered in our patients. Now I'll turn it back over to Dr. Sue.
Thank you. So which dosage forms can be used in neonates? Dr. Shah actually went over many of the intravenous formulations. I'm going to focus on a variety of different products. So as many of us know, there are quite a few available dosage formulations, and the list I have here is not even an inclusive list. So what is the one that we would like to have most tailored for the neonatal population? And the two most common dosage formulations that are most primarily used in neonates are really the liquid formulations, whether it be a drop, solution, or suspension, and also primarily the intravenous formulations. However, there are so many other products that comes in many different various dosage forms, and if we have to use it, we will use it in the neonatal population. So the neonatal dosage formulation considerations, compounding, especially extemporaneous compounding, so oral liquid compounding and intravenous compounding is very common in our everyday clinical practice. Stability and safety concerns we do worry about prone errors, and we also need validation for compounding, as not all extemporaneous or even intravenous compoundings may necessarily be available in the literature or even has been studied in these populations. So we do count on commercially available products, but we unfortunately sometimes may not have a product that may be feasibly administered in this population. So concentration, and Dr. Shah kind of alluded to, high concentration does require multiple dilution, such as what we call serial dilution, and they take the solution form and even further diluted it, and maybe not just one time, but multiple times. And then low concentration, we do worry about volume overload. As mentioned earlier, enteral feeding nutrition is very important, especially in many of our small microPMEs and neonatal population. So if a concentration of an oral solution, it has a low concentration and their volume, for example, takes up 10 mLs, what if each feed that they take in is only 10 mLs? So when it comes to a low concentration, we don't want to give them too much volume because we would need to subtract and deduct their nutritional requirements if it matches or becomes too much for them to kind of lead them to volume overload. This is just an example by Allegaert et al. And what they did was that just to pose an example, and these are concentrations and product availability from Belgium of what sequential dilution in neonates does look like. So as you can see in this table here, there's an example for preterm and there's an example also for term with different weights. And based on this, we note that depending on what available concentration there are, several serial dilutions may be necessary in order to administer a feasible dose that can be given to a neonatal population. And as you can see here, it also varies whether they're a preterm versus a term neonate, and as of course, if they are older as well. So another thing with these oral products is osmolality. The American Academy of Pediatrics recommends that an osmolality of enteral nutrition should really not exceed over 450 milliosmol per kilogram. And the reason for that is really to prevent any complications in the neonatal population regarding gastrointestinal complications, such as necrotizing enterocolitis. So we want to keep an osmolality that is feasible and also for an environment for the gut. Studies have suggested that a maximum osmolality of 500 milliosmol in low birth weight infants are considered safe. However, a study that was done by Dr. Shaw and myself and many of our colleagues, Shaw et al., we determined that the osmolality of commonly used oral medications that are currently in the market actually are greater than 500. And as you can see that this is not our recommendation that we know that suggests what the maximum osmolality should be administered in this population. So in this particular study, we found that 37 out of 42 medications that was tested showed about 88.1% were greater than 500 milliosmol per kg. So let's take a look and dive into a little deeper what this literature shows. So the medications, there were 42 medications that are listed here, and what they were done when it was looked at was to take a look at what the osmolality range was. Majority of the osmolality range was between 1,000 to 4,999 milliosmol per kg. And as I mentioned earlier, we try not to, the recommendation is not to exceed 500. But majority of the medication we use in the neonatal population, as you can see here, does exceed that amount. And we even have 11 medications that are greater than or equal to 5,000, which is our second largest group of oral medications that we give in the neonatal population. So what are these medications? And these are the 11 medications that are listed here. And with these 11 medications, you can see over here that many of them are greater than 5,000. Even with no surprise, glucose oral gel, which I'm going to dive into a little more, the gel itself has over 10,000 milliosmol per kg. And even a common medication that we use in neonates, such as multivitamins, even have an osmolality greater than 10,000. So many of these medications that are commercially available in liquid formulation, unfortunately, is not ideal nor feasible in our population in neonates and do exceed the recommended 500 limit of 500. So if we look into more of specific medications and what have changed over the years, the next few groups of slides that I'm going to go over is really to see what has evolved in the market that has helped us in the neonatal population. And what we want to see is how can we make more of these so that it makes it much easier for us to administer, not only for healthcare providers such as our nurses to administer these medications, but also caregivers at home to administer these medications. So a particular one I just want to mention and kind of describe is the use of hydrocortisone. And I'm going to focus on in this particular case, specifically for the disease state of congenital adrenal hyperplasia. So congenital adrenal hyperplasia, as you can see, is babies are born with this. It's considered a congenital autosomal recessive gene mutation, and particularly affects the hydroxy-21 deficiency. And when the 21 hydroxy deficiency does occur, unfortunately, they have an inability to synthesize cortisol and aldosterone in these babies. So the dosage recommendations based on our guidelines is to recommend the use of hydrocortisone. And specifically in the guidelines for congenital adrenal hyperplasia, they recommend to use the tablet formulation and not the suspension formulation 3 times a day with a recommended dose of anywhere from 10 to 15 milligrams per meter square per day. And the reason for not the suspension that was listed in these recommendations was because in 1998, there was a suspension that was available known as Cortef suspension, and this was removed from the market. The reason why this was removed from the market was that it was found that the suspension was not considered bioequivalent compared to the tablets for the treatment of CAH. Hence why it was recommended not to use the suspension. Now, the focus was on this product. A lot of the focus was primarily on this product back then that was commercially available as a liquid formulation. There has been, since there was no liquid formulation and the only other available formulation was available during this time was the oral tablets, people were coming out with compounding recommendations. There is a formulation that can be compounded in the 2 milligram per ml compound that is still considered stable for approximately 90 days. However, because the guidelines do say that the tablet formulation is recommended and not to use the suspension, many endocrinologists have alluded to actually having families take the hydrocortisone 5 milligram tablet, which is how it comes in, and to cut the tablet to as small as a quarter tablet. And as many of us know, it is a certain technique. Hydrocortisone tablets are very, very small. And for many of our families, it was very difficult for them to use the pill cutter to actually cut it nicely to a quarter tablet and then crush it to administer to their baby. So it was a very challenging and difficult, and hence why some of them resorted just to get the extemporaneous compounding, because many times when they were trying to cut the tablets were being completely just crushed. So what is available now that has recently come to market, which has really helped us, especially for many of our caregivers to administer for their CAH patients, is the hydrocortisone sprinkles. This is what the manufacturer has done was make it applicable for neonates. And as you can see here, there are sprinkles that are capsule filled, and it comes in dosage forms that anywhere from 0.5 milligrams to 5 milligrams. And many of our endocrinologists now actually use these formulations when it came available, because it really helped us from families from cutting tablets from small hydrocortisone oral tablets to make it feasible for their baby to actually take the medication. And if you even think about it, even when families were trying to cut the tablets from a 5 milligram tablet and take a quarter of it, we're talking about 1.25 milligrams, where these sprinkles actually go down to 0.5 milligrams. So it avoids families and even caregivers to manipulate the dosage form of hydrocortisone. It also avoids them from actually finding extemporaneous compounding pharmacy to actually do this. And I know we are shortly running out of time, so let me go over the rest of my slides. Additional dosage formulations that we do have available, unfortunately, with manipulation in the neonatal population include nasal spray, rectal inhalers, topical, and suspension. Some key points I just want to mention in this particular slide is that nasal sprays, they're unfortunately not marketed small enough for neonates' nostrils, because their nostrils are very small compared to older kids and adults. And the other thing is with topical agents, we have to consider that they have a thinner layer of the stratum corneum, which allows, and they have much larger biodistribution, which increases the absorption of topical agents. Another thing I do want to point out, most feasible in the neonatal population is really to administer nebulized formulation of medications, but there are breath actuated inhalers that we may need to use in this population, such as this one over here that's listed, such as QVAR. And if you can see that this ready inhaler, this QVAR formulation, which is also known as beclomethasone, is really not feasible for our neonatal population to use. So we do require an unapproved manipulation of the product to use a spacer with this agent. So many of you may have heard of overdoses with heparin over the years, and this is what an actor, Dennis Quaid, and his twins were affected, as well as many premature babies and neonates in the neonatal intensive care units throughout our country in the United States, where there was a 1,000-fold increase of an overdose with the use of heparin. And as we know, heparin overdoses can lead to bleeding. And as you can see with the evolution of heparin, the packaging itself has evolved over the years. And now we hopefully have a tear-away label that is considered safe and effective to prevent such a horrible error from happening again. But unfortunately, the physical appearance and safety of common medications that we use in neonates are not fully disappeared. They still exist. So on the left-hand side here, you can see vitamin K1, also known as photonodione, and there is 2 dosage formulations here. There's a 10 milligram per ml, which is commonly used as an antagonist for vitamin K in the adult population and even in some pediatrics. But then you also see on your right vitamin K 1 milligram per 0.5 ml. But look at how similar they are. We use the one in neonates, the one on the right, the 1 milligram per 0.5 ml, which is primarily used for vitamin K deficiency in our newborns. And then even on the right-hand side, I don't know if you can even tell the difference. The left one for the caffeine citrate is for oral use, and the right one is for intravenous use. And the oral use product looks almost exactly the same as the right-hand side. The only difference with the oral use format is how the packaging is like when it's open. So over here, you can see directions for the oral caffeine citrate of how families and healthcare providers do open it. It's basically a plastic cap that they pull out. The intravenous one, as we know, requires a IV needle to actually go in to extract the medication. Unfortunately, when we had a major drug shortage with caffeine citrate solution, the IV formulations were being dispensed to families if they went home on caffeine citrate, and families had no way of extracting an oral dose with the IV vial that was given to them. So that's something that to try to make things not appear exactly the same and make it more feasible for extraction of the medication would be helpful in our neonatal population. And I just want to chime in, Beth, and are we good? Should I keep on going or should I just cut it short very quickly with my presentation?
I think we need to probably cut it short. I think we're going to have to close out soon.
Okay, no problem. So what I'm going to do is I'm going to highlight in the neonates an example of how we package unit dose medication. So this is what we do at my institution in the hospital, where you notice that many of the oral medications are bulk bottles. And in order to give neonatal specific drug doses, we actually have to put them in oral syringes and also barcode them so that they provide safe administration to the right baby and the right dose. And we do this every single day, multiple individual patient specific doses all the time. What's nice now is that some commercially available manufacturer products have a barcode, which allows it easier and much safer, because we know barcoding is much safer for administration, especially in a hospital institution. And this is just some examples of sucrose 24% and glucose gel 40%, in which what's commercially available as a large bulk, but now they have made smaller ones, which is unit dose and barcoded for our neonatal population. And with that being said, I do want to just summarize regulatory policy and scientific research have led to neonatal developments, and drug formulations in neonates really require special considerations, intravenous concentrations and compatibility, oral formulations, and also be mindful with the excipients, osmolality, and how the packaging is also produced. They are a vulnerable population, and delivery of safe and effective medications are definitely essential in this population. And with that being said, Dr. Shaw and I would be happy to answer any questions regarding our presentation, and this concludes the end of our presentation.
Thank you very much to both of you. I'm really sorry we had to rush at the end. I'm sure you could speak for hours on your topics, but thank you very much for a very informative presentation and for sharing your practical experiences. We do have a couple of questions. Yes, one to answer the slides I believe will be shared. Mahalia, can we go on with a couple of questions?
Let's take a couple of questions.
Okay, we've got some here. So one on the intermittent medication issue slide, why do nurses need to administer the medication using a pump rather than simply pushing a bolus dose?
Pooja, do you want me or you to answer?
I'm just going to repeat the question. So it's why do nurses have to administer it through the pump instead of just pushing the medication? So that's a very good question. So one of the main reasons is for controlled time delivery. So for example, indomethacin has to be given slowly over 1 hour. This has shown to be very advantageous because indomethacin can cause vasoconstriction, which leads to a whole sorts of negative effects, which I won't go into. But giving something like 0.4 mLs over 1 hour for the nurse to stand there is not feasible. The other thing is that our pumps have actually many safety checks in place that are built in. So we didn't quite get to go through barcoding, but when you're barcoding the medication, you know that the medication is appropriate, it's dosed appropriately. The pumps are actually quite advanced in checking and making sure that it fits an appropriate milligram per kilo. It's the appropriate drug, appropriate dose, and then it ensures that the delivery is over a specified time.
And I just want to add to that as well too. The pumps that we use nowadays are known as what we call smart pumps. So these smart pumps actually have like a computerized database where each individual medication that is administered has built-in minimum and maximum doses in order to prevent medication error. So in this particular case, like indomethacin, if we try to infuse it over, let's say, an IV push or IV bolus over 5 minutes, the pump would automatically prevent the nurse from doing that.
Thank you. Okay. Can you please comment on how the dose is selected for neonates? Equivalent per body weight dose as adults, exposure matching, or something else?
I think I heard the question is, can you expand on how the dose is selected for neonates? So that's a great question. Most medications in neonates are weight-based. So it's milligrams per kilo, per dose, or per day. The amount, so the milligrams per kilo, is based on the patient's gestational age and their age postnatal. So for example, the dose that you would give a very low birth weight infant is going to be different on a milligram per kilo basis. And I'll just give you a quick example. Gentamicin, for example, for a very low birth weight infant, you may give 4 milligrams per kilo every 48 hours. Once they're older, so if they're 7 days old, and that's what I mean by older, they'll get 4.5 or 5 milligrams per kilo, depending on their age and days after birth. So the amount that's given is also not consistent within that neonatal age group.
Yes. And the other thing I do want to mention that we do have to think about when we dose neonates is that their renal function technically should improve as they age. So usually their renal function does get greater than 7. After 7 days, they do improve. And then with that, we would dose it more frequently. So we may go from every 48 hours to every 36 to every 24 hours.
Okay, thank you very much. And I apologize for my audio. I'm assuming you can't really hear me very well. Okay, one last comment before we close. Comment with regard to excipients. Absence of evidence of harm is not the same as evidence of absence. I'm sorry. Absence of evidence of harm is not the same as evidence of absence of harm. Safe amounts for neonatal intake may not have been established for many excipients. For all new drugs to be used for neonates, manufacturers should be required to discuss the evidence for use in neonates and risk assess with regulators the use of alternatives for need for use for further study. Sorry, not sure if you caught that. It's written in the question, so we can communicate that to you separately.
I'm sorry, Beth. I don't think I fully heard the question.
I think it's a comment. But
The question is, what is the speaker's experience about having to use an oral medication for neonates? Did they have to suspend it in water or other vehicle? Also, does using an enteric tube limit the use of solutions, or can suspensions also be used?
So I'll answer the first question. So our vehicles can vary depending on what is recommended in compounding. So all our compounding generally has recommendations based on studies for extemporaneous compounds. So not our vehicles, we could use oral plus. For example, they could be just suspended in water. They may require some other vehicle that is meant for oral solution compounding. So it could be a variety of different things. And then if I understand.
And then the second portion was, can you use an ET tube, like a nasogastric tube? It's not an ET tube for oral medications, but you can use either a nasogastric tube or a different type of gastric tube to administer suspensions. Yes.
Yes. We also sometimes do oral gastric tube as well as nasogastric tube. So we either go through their mouth or their nose.
Okay, there's one more question. Are oral meds ever mixed into the enteral nutrition to overcome liquid restriction?
Yes and no. So it doesn't limit the fluid volume. So we don't necessarily mix medications to dilute them in enteral nutrition. So we wouldn't necessarily mix, for example, if we were to mix a medication, we wouldn't mix it with breast milk, but we often do use breast milk as an additional vehicle to deliver the medication. So we would, one, it helps decrease the osmolarity. Two, it can sometimes help acceptance, especially in older neonates. They'll, take the breast milk and that'll contain the medication in it. But we wouldn't necessarily dilute the medication itself in breast milk.
And the other comment, I actually get this question from caregivers. Can they take their, when their babies go home and they're taking the medications at home, can we take their medication and mix it with the breast milk or mix it with formula? I always tell them to be cautious with that because the baby may not finish the entire bottle and they may not finish the entire volume. So just to be cautious because if they only drink half of it, they don't know exactly how much of the medication they actually fully got.
Thank you. And thank you, Mahalea, for helping me with the questions.
We will be circulating a survey regarding this webinar. We really appreciate your input and your feedback regarding the content, the topics, and if you have any interest in speaking at this forum, please contact Beth Gallela or myself or David Tan, and we'd be happy to have a conversation with you about that. And with that said, we'll go ahead and sign off. Thank you all very much. Have a great rest of your day.
Thank you.
Right.